Hussam, are you hearing me?
Yeah,
Yeah,
we can hear you very well, and we are live now, okay?
Okay, so Dr. Osama, you will start and I will take over, right?
well, I would like to welcome our distinguished speakers, Dr. Al Anoud, Dr. Raed, Dr. Shatila, and Dr. Abu Laban, and thank you for accepting our invitation to be with us this evening. I'll leave the opening remark, the introduction to you, Dr. Maya, but before starting, I would like to thank Gen Farm for the amazing partnership and for supporting the knowledge transfer journey at IVPN. Welcome our speakers. Thank you, Dr. Maya, for moderating this session, and I will leave the screen, the stage, and the mic for you. Dr. Maya? Maya? Hussam, are you with me?
Thank you.
Yes, we can
Thank
hear
you.
you.
Yeah, thank you, Dr. Osama, for the introduction and for being with us tonight. Good evening, everyone, and welcome to this IVPN Neuropsychiatry educational webinar entitled Practical Insight for Managing Myasthenia Gravis, Bridging Theory and Clinical Practice. It's really a pleasure to have all you with us tonight, and I know you are very numerous. And I would like to warmly thank our sponsor, Gen Farm, for supporting this scientific activity. And as Dr. Osama mentioned, helping us bringing this important program to the neurology community in our MENA region. So, as you know, myasthenia gravis is an autoimmune neuromuscular disease characterized by fluctuating muscle weakness and fatigue. And although it is considered a rare disease, its clinical complexity, diagnostic challenges, and therapeutic advancement have made it a rapidly evolving field lately. And in the past recent year, we have seen really major shift in the diagnostic pathway, earlier detection strategy, but also the introduction of highly targeted effective therapy that have really transformed patient outcome in the management of the disease. Today's program is designed to bridge the clinical evidence with the real world challenges and to provide practical strategies and insight from our expert neurologists so you can apply the knowledge in your daily clinical practice. We are really lucky to have an excellent faculty joining us tonight, and I am honored to have you today and to introduce you. So, with no further ado, I will introduce to you our first speaker, Dr. Al Anoud Al Sulayhimi. Dr. Al Anoud is a consultant neurologist and section head of the Neuromuscular Integrated Practice Unit at King Faisal Specialist Hospital in Riyadh. She completed her fellowship in neuromuscular disease and EMG at McMaster University in Canada and is a certified diplomate of the Canadian Society of Clinical Neurophysiologists. Dr. Al Anoud will start this webinar by discussing the epidemiology and burden of myasthenia gravis in the Gulf region. Thank you, Dr. Al Anoud, for being with us tonight. Welcome, and the floor is yours.
Good evening, everyone. Is my screen clear to start?
Yes, doctor, perfectly clear.
Okay. Good evening, everyone. Thank you for joining today. I'll be reviewing the burden of generalized myasthenia gravis and also the rationale behind the targeted therapy. So before getting started, Maya already mentioned a brief about myasthenia gravis. So this slide is talking about an introduction of generalized myasthenia, which most of you would know that it's a chronic immune-mediated neuromuscular disorder. And mostly this disease would start in the eye, so ocular. So the patient would present to you with double vision, ocular symptoms such as ptosis as well. And 80% of those would tend to generalize. Meaning of generalized myasthenia is those symptoms spread from ocular down to the body, and the patient would start to develop bulbar symptoms, generalized fatigue and weakness. And what we're afraid of in this condition is the myasthenic crisis, which we know that 20% of those patients, they would have myasthenia crisis, which we try to avoid by giving the patient, early medication and intervention. So when we talk about a global incidence of myasthenia, it still remains rare, around 0.3 to 2.8 per 100,000. However, still mortality is around 5 to 9%, which is, usually is because of respiratory failure and myasthenic crisis, which we tend to or try to avoid with medication and the targeted therapy that we give to patients. So as you all know, it's a bimodal disease. So there is two age peaks. The common one is between 40 to 50, which tend to see in female. But nowadays, commonly, we tend to see older population presenting with myasthenia, especially around the age of 60, 70. And in terms of gender, it's all the same, men and women, but we tend to see them nowadays more. So we notice that there is an increased myasthenia gravis prevalence. Why is that? It's not because the explosion or the number of the patients that started to come up recently. It's probably because of better diagnostic, early diagnosis, and also availability of antibody testing that tend to have a good impact on catching those patients early. There is a special notice in a cohort of patients, mainly Asian population, that it was noticed that ocular myasthenia is more common in those patients, and also anti-mask positive patients tend to be more common when we compare it to overall global population. When we talk about hormonal influence on myasthenia, we know that 41% of pregnant ladies, they tend to have worse presentation of myasthenia, especially in the first trimester and post-partum. And also, it has been reported that premenstrual phase tend to have worse presentation or worse clinical presentation on those patients. As we all know, that quality of life has an impact and a great factor on myasthenia. And the quality of life factors is usually tend to be affected by, level of education, mental health, and disease acceptance, and also, a certain number of patients, such as elderly patients, show lower tolerance to immunosuppressants. So we have to keep this in mind, and this is important to tailor those medication based on the patient population. So when we talk about GCC specific data, there is no well-established data about, the incidence of myasthenia in the region. But there was an old study in 1991 that reported that the prevalence of myasthenia is around 0.5 to 100 per 100,000, which is similar to the global population. In the United Arab Emirates, there is no published incidence. However, there was a recent GCC consensus that was recently published by a GCC experts group, and they agreed that the incidence of myasthenia is similar to global population. They also noticed that most experts, around 66% of them, they would treat around 10 to 59 patients. However, around 30% of the group tend to treat more than 60 patients. So this highlights the significant presence in myasthenia in daily practice. So when we shift gear to comorbidities associated with myasthenia gravis, this data set showed that some comorbidities are commonly associated with myasthenia. So myasthenia or neuromuscular junctional autoimmune disease does not come alone, usually comes with another comorbid condition. And it was noticed that most of those patients, they tend to have thyroid disease, some of them anxiety and hypertension. And when we talk about, clinical response or disease control of myasthenia, we always talk about MGADL. What is MGADL? It's a patient-reported outcome, which is activity of daily living, which usually focus on 8 domains, and it ranges between 0 to 24. The higher the number, the worse the disease, presentation. And our target is between 0 to 1, which we call it MSE or minimum symptom expression. This is our target. And we notice in this, Dutch-Belgian myasthenia gravis registry that MGADL and patients who are on a traditional treatment such as pyridostigmine, steroids, immunosuppressant, and non-steroid immunosuppressant agents such as isotretinoin or mycophenolate, they tend to have MGADL above 3, which is unsatisfactory symptom control, which, it's not the target in here. When we talk about patient experience on those who starts on steroid, we know the steroid burden on, the patient and the major impact in terms of side effects on the patient quality of life and health. Over 33% of patients on steroids, they reported side effects such as tiredness, weight gain, mood swings, insomnia, and so on. And when we talk about, comorbidities associated with the steroids, we all know that most patients who are on steroid, they tend to have prediabetes, commonly weight gain, pedal edema, insomnia, and so on. And also when we talk about, potential long-term health effect of patients on steroid whom are, myasthenic or others, they noted that most of those patients, they are having, thyroid-related disorders, sleeping disorders, osteoporosis, malignancy, infections, and in this retrospective cohort, they noticed that the mortality is twice on those who were kept on a steroid, most likely secondary to pulmonary embolism, pneumonias, and sepsis. And, despite traditional treatment, we know that myasthenia in general affect quality of life. And when you talk about psychological impact, this group of patients were studied, or more than 1,000 patients. They noticed that 18% of those patients, they would have moderate to severe depression, compared to 6% in the general population. And also around 70% would have an anxiety when you compare it to 20% of general population. So indeed, myasthenia does affect the patient psychologically. And also when we talk about impact in employment, the study noticed that over the past 1 month, they look into patients with myasthenia, and they noticed that 57% of those patients, they are either not working or not studying because of myasthenia. And, absence days from work is about 13 days per month, which is almost half of the month. It's because of myasthenia, or it's, side effect related to the medication. Not only, myasthenia impact the patient itself, it also impacts the caregiver as well. So 36% of patients reported that they need a caregiver during their care. And we know that, there are a burden or, a challenge when you diagnose or treat those patients. Because of the nature of the disease itself, it fluctuates. So the patient would come to you presenting with zero symptoms, but down the line, at night or end of the week, they would have the symptom back again. So the symptom tend to fluctuate, which is which negatively impact approaching or managing those patients. And also when we look at the patient-reported outcomes, such as MG-ADL or other patient-reported outcome, it doesn't address the overall clinical condition of the patient. So the patient might be clinically ill, but he might score very well in this scale, and the vice versa. So there is a great limitation and a negative impact of those scales when we talk about the disease itself. And also poor quality of life, as we mentioned previously, related to myasthenia. So when we talk about the therapy, the targeted therapy, the new targeted therapy, the aim of those therapy is it's targeted. So it targets the pathophysiology of, the disease itself. And our hope is to maximize the efficacy of this agent and minimizing side effects. As you all know, the limitation of the traditional therapy that we use in myasthenia, such as pyridostigmine, which is only a symptomatic effect, and non-steroidal immunosuppressant therapies such as azathioprine and mycophenolate, which tend to have a slow onset of action. We know that we need about 6 months to a year for the medication to kick off. And as I mentioned previously, the unsatisfactory symptom control with the conventional therapy. And we know that it tends to cause a generalized immunosuppression, which we don't want, and it carries chronic side effects related to the medication itself. My colleague will talk about the mechanism of action of one of those agents called efgartigimod, which targets FcRn. So I'm going to skip this. Before I end, a summary of what I just mentioned. As you all know, myasthenia is a chronic immune-mediated neuromuscular junctional disorder. And despite treatment and support, many patients still suffers from substantial disease burden, and the true burden of myasthenia might not be that obvious given the nature of the disease and the fluctuation. Multiple patient subpopulation remain underserved, lacking evidence-based, targeted, effective, and well-tolerated treatment option. So our target or our aim is to find a treatment that maximizes efficacy while minimize side effect. And as we mentioned, the consensus guideline, the GCC guideline, mentioned and supports that MG incidence in the GCC is estimated to be similar to global population. And I'll leave the mic to the next speaker. Thank you.
Thank you, Dr. Al-Anud, for a very comprehensive presentation. So we'll, as agreed, we'll take the question for Dr. Al-Anud after Dr. Al-Rughani lecture. And now we move to our second lecture and second speaker. It's my pleasure to introduce Dr. Raed Al-Rughani, who is a consultant neurologist and director of the Multiple Sclerosis Clinic at Amiri and Ibn Sina hospitals. He has authored more than 230 publications in the field of neurology and is a founding member and general secretary of the Menectrem's Society. So Dr. Raed will talk to us tonight about the diagnosis of myasthenia gravis. How do you diagnose myasthenia gravis? Its a clinical feature and pathogenesis. Thank you, Dr. Raed, for accepting our invitation despite your super busy schedule, and the floor is yours.
Thank you, Dr. Amaya, for your kind introduction, and thanks to the IVPN NeuroPsychiatry for the invitation. So these are my disclosures, and this is the content of the lecture. Hopefully within the next 20 minutes, I'll try to give you an overview about the diagnosis and pathophysiology. And I think to start, first, I think MG is mainly a clinical diagnosis. So I think the clinical presentation was presented by the previous speakers. So usually we use our clinical opinion with a supportive testing or biomarkers to reach a diagnosis. And of course, sometimes we have to combine to reach a definitive diagnosis rather than a possible diagnosis. Now, the clinical assessment relies primarily on the history and your neurological examination. According to the Japanese criteria, if you have one of the following symptoms, then you have to consider myasthenia in the working diagnosis. And especially if these symptoms are exertion dependent and fatigable. So those symptoms would be ocular, like ptosis, diplopia, bulbar, facial weakness, dysarthria, dysphagia, chewing difficulty, dyspnea, or limb or neck weakness. And myasthenia by nature, especially when we talk about generalized myasthenia, is a fluctuating and goes into remission and exacerbations. So there are periods where patients have no symptoms or they have minimum symptom expression, especially if they are controlled, what we call it pharmacologic remission. They may go into a period of exacerbation where there are new symptoms, worsening symptoms, and at times they actually may go into a crisis where they may need a respiratory assistance. So if we don't control most of the symptoms, they may go into a period of exacerbation and possibly a period of crisis. Now, in order to confirm myasthenia, apart from the clinical assessment, the most important serological test would be anti-acetylcholine receptor antibody, which is positive in most generalized myasthenia, and around 50% of the ocular myasthenia may have positive acetylcholine receptor. Now, in those with negative acetylcholine receptor antibodies, around 30 to 40 of those patients may have MuSK, which is generally represent less than 10% of the whole myasthenic patients. The anti-LRP4 antibodies are very rare. They may present in around 20% and up to 20 to 30, 40% of the seronegative cases. Now, in those with thymoma and presenting with generalized myasthenia, around 30% may have an additional anti-striated muscle antibody, especially if they are younger than 40. So the serology test is the most important diagnostic test. However, sometimes we rely on other tests like the EMG or repetitive nerve stimulation. And repetitive nerve stimulation is not that sensitive, especially if the patient have only ocular. Look for decremental numbers in the CMAP. If you have more than 10% decrement with exertion, then this is in favor of neuromuscular junction blockade. The single fiber EMG is more sensitive but less specific, as it can be present in other neurological disorders. So we are looking for jitter mostly in this. Now, if you have a clinical suspicion and a positive acetylcholine receptor, you probably don't need an extensive testing. You will need, of course, the CT or MRI of the thymus to look at the thymic hyperplasia or thymoma, which might be very important in seropositive acetylcholine receptor MG patients. Now, false positive may occur, so that's why you have to really rely on your clinical judgment, and sometimes you may need to repeat it. And overdiagnosis is similar to the underdiagnosis, may actually be a culprit for unnecessary treatment. So this is a summary of the generalized myasthenia. As we said, 85% will have acetylcholine receptor. Around 5% may have anti-MuSK, and around 1% may have LRP4. Sometimes we talk about double seronegative or triple seronegative. So if you cannot find any serological seropositivity, so this might be two different reasons. First, maybe the antibodies levels are below the detection limits. Maybe the patient have autoantibodies against epitope that's still not detected by assay, or sometimes we don't have a known target for the neuromuscular junction pathology. And when we talk about diagnosis, we'd like to classify patients into ocular, bulbar, and generalized. Now, the ocular myasthenia, most of them may progress within 5 years to generalized myasthenia. So at initial diagnosis in the first 2 years, probably 50 to 70% may have acetylcholine receptor positive. When we talk about classification according to severity, there are many classifications. The most common used is the MG Foundation of America classification, where they classified mild patient to class 1, and then mild to moderate class 2, and 3 to 4 moderate to severe. The German guidelines try to use a disease activity as a classification in addition to the MGFA classification. So basically they try to accommodate the severity and activity at initial diagnosis. So if a patient has one exacerbation control, then they call it mild to moderate disease activity. However, if they have multiple exacerbation within a year with plus minus uncontrolled or inability to reduce steroids, then they will classify it as high disease activity. Now, at the end, I think the clinical judgment remains the main important factor in the decision when we decide on treatment. So sure, investigation may aid in diagnosis, but again, the management gonna be driven mainly by the clinical judgment, especially if the antibody testing is positive for acetylcholine receptor. There are also outcome measures being used in the clinic and also being used in the clinical trials. The most common two outcome measures are the MG-ADL and the QMG. The MG-ADL is a patient-reported and focused on the daily functional impact. And it's very quick, simple, and you don't need any training or equipment. While the QMG is physician-rated to evaluate the symptom severity across multiple muscle groups and usually designed to correlate with antibody titers in the trials. There are other measures, but I think these are the two. And we usually like to have at least one subjective and one objective measure to give us the what we call the final impression on your evaluation. And there is an Arabic validation in the GCC for MG-ADL and MG-QOL, which may also use to ensure the cultural and linguistically accurate assessment. This is the MG-ADL, which is one of the patient-reported outcome, and you can see it consists of 8 items and a score 0 to 3, and a total score 24. 0 is normal, 24 is severe. There is no instrument needed, and it's very quick to administer that at the clinic or even online if the patient want to administer it at home. This is the QMG scale. It's a 13-item driven assessment done by the physician, and each item is measured on a 4-point scale, and it ranges from 0 to 39. Again, higher scores indicate greater disease severity. Now, talking about the pathophysiology of myasthenia, and we know it is one of the neuromuscular junction disorders, and it is postsynaptic disorder. We know that the transmission, the motor transmission, begins with an action potential propagating to the motor nerve terminal, where the acetylcholine receptor is released in the synaptic cleft, and then the acetylcholine binds to the receptor, triggering the opening of the ion channel and leading to depolarization at the motor end plate. So acetylcholine receptor clustering is critical and efficient to guide the transmission of the motor unit. So any limitation in the clustering or any blockade around the acetylcholine receptor may lead to a dysfunction in the neuromuscular junction. And we know there is a presynaptic, synaptic, and postsynaptic disorders that can cause neuromuscular junction disorder. By far, the postsynaptic, like the myasthenia, is the most common. Also, when we talk about the pathologic entities of IgG autoantibodies that may result in the development of neuromuscular junction blockade, it usually starts at the thymus level, where there is a loss of immune tolerance, and then there is a development of the pathogenic IgG autoantibodies attacking the neuromuscular junction. And by different models, maybe there is a different mechanism where the neuromuscular junction been attacked. But there's one thing that you have to be aware is what we call the recycling of the neonatal Fc receptor. So the recycling will prolong the availability of the IgG antibodies, which is central to disease pathology. So if you block the recycling of the neonatal Fc receptor, this will limit the disease pathology. There are three ways where generalized myasthenia may result from either a functional blockade of acetylcholine receptor binding site. There might be a cross-linking and internalization of the acetylcholine receptor. And the third, which is also a very common pathogenic mechanism, is antibody-dependent complement activation. So it depends which mechanism you target. This will lead to a different pharmacologic and what we call targeting drug. Now, all IgG antibody subtypes may contribute to the generalized myasthenia pathophysiology. The IgG3 is mainly driven by the complement activation, whereas IgG1 and IgG2 usually are mostly related to the neutralization of the receptor. So the neonatal Fc receptor plays, as I said, a crucial role in extending the half-life of the IgG antibodies. Once the neonatal recycle the IgG antibodies and albumin by saving them from lysosomal degradation, this recycling results in IgG antibodies having longest half-life and being the most abundant of all immunoglobulin. Efgartigimod is a human IgG1 antibody Fc fragment engineered to increase the affinity of the neonatal Fc receptor versus the endogenous IgG, thereby selectively reducing the IgG level and reduce the pathologic mechanism of myasthenia. So in summary, I tried to show you that the diagnostic pathway of myasthenia remains clinical, supported by serological and other tests like EMG and the imaging to look for thymoma if the acetylcholine receptor is positive. The MG-ADL and the QMG are the two main international clinical scoring systems that used to assess the disease severity and response to treatment. The IgG autoantibodies are the key mediators of the generalized myasthenia pathophysiology and reduce the number of available acetylcholine receptor at the neuromuscular junction through three distinct mechanisms, either the functional blockade of acetylcholine receptor binding site, also the internalization of the acetylcholine receptors, and the anti-dependent complement activation. And with this, I'll thank you for your attention.
Thank you, Dr. Raed, for a very insightful presentation about really the complex pathogenesis of myasthenia gravis and its diagnosis as well. So I would like to ask all our participants to share their questions for Dr. Al Anoud, and for Dr. Raed Al-Rughani in the chat and box, in the chat box, so you can benefit from the expertise of their expertise to answer your concerns or any question you might have. So please write your question. We'll take like a 5-minute question before we move to Dr. Abu Laban and Dr. Shatila presentation. So Dr. Raed, I have a question for you regarding the differential diagnosis of myasthenia gravis. So what are the diseases that can mimic myasthenia gravis?
That's a good question. So it depends on the presentation. If it is ocular, for example, we have to think about other neuroimmunological diseases or sometimes genetic diseases. So if the patient have ophthalmoplegia, for example, you have to think about progressive disorders like CPAO. You have to think about a brainstem pathology, either a stroke, a glioma. Now, if they have a limb weakness or bulbar weakness, it depends on your exam. If it is an acute, you have to think about AIDP or CIDP, which is the acute inflammatory demyelinating polyneuropathy or the chronic form for it. And so all your exam going to be very helpful here to localize. Brainstem pathology is very important if you have bulbar and ocular. Sometimes there are some mimickers like a thyroid eye disease may do the same. Sometimes polymyositis kind of present with limb and neck muscle weakness. So it depends where's the localization and what's the actual presentation. So your clinical exam gonna tell you whether this is a central or peripheral localization, and then once you decide whether it's central or peripheral, then you have to judge whether this is a radiculopolyneuropathy, neuromuscular junction disease, or primarily muscle disease.
Thank you, Dr. Raed. So I have a question from our audience, and I think I would like to both of you to answer this question. So to take an insight from all our expertise. So one of our attendees is asking, in case of poor response to standard immunosuppressive therapy, how do you distinguish that this is failure to treatment versus disease fluctuation? And do you currently rely on biomarker or any clinical indicator? Do you personally in your clinical practice rely on any biomarker or clinical indicator to guide you on when there is need to shift therapy or to escalate? Dr. Al-Anoud, you want to start? And then Dr. Raed will follow.
Yeah, so you should know the difference. So fluctuation, the symptoms as comes by the end of the day, and usually when we say fluctuation, that we allow is if it's after fatigue, if the patient is tired, if it's mainly ocular, but if it's bulbar, if the patient have choking, breathing issues, this we call it a treatment failure, and we should escalate therapy. And there is no antibody or biomarker that can predict the clinical response or indicator, but we usually rely on MG-ADL in our clinical practice. And in addition to our clinical exam, as Dr. Raed previously mentioned, so you examine the patient fully, and we usually give the patient also MG-ADL and MG quality of life, and then we see if it's if the number is higher than 6, in addition to your clinical exam is does not abnormal. At this moment we might escalate therapy.
Dr. Raed, what's your practice?
Yes, I agree with Dr. Al-Anoud. Now, when we say no response, means that either the patient is not well controlled on the immunosuppressant, either having relapses, or he has symptoms which are not what we call minimum symptom expression, so more than that, or if there is inability to reduce the steroids, so high dose and we are unable to reduce it, then again this is a poor response to the immunosuppressant. Now, if a patient has a crisis, this is a clear cut. I think there is no question. There is a poor response. Now, whether there is a marker for this, you probably have to, rely on your clinical judgment. And we always use what we call global clinical impression. So you will know your patient if he's doing well or not. And it's not only fluctuation.
Yeah, also to add, we usually also use MGFA score. So 0 to 1 is we allow. So 1 is ocular, which is okay. But if it's past ocular, we usually reconsider, medication as well, adjusting medication.
Thank you, Dr. Raed and Dr. El Anoud. I have one question. Does multiple antibody exist in the same patient?
Yeah,
To my
go ahead, Dr. Anoud.
To my knowledge, we have rarely encountered multiple antibody patients. I'll leave it to Dr. Raed if he has an experience with this.
Yeah, it's very unusual to have two antibodies for neuromuscular junctions, usually one. Now, you may have other antibodies for other disorders. For example, you may have anti-GAD positive, which is not related. You may have thyroid antibodies, which are maybe related to the autoimmune phenomena, but not to serological markers for neuromuscular junction disease.
Yeah, thank you. And another question, Dr. Raed, what about the difference in prognosis between the different subtypes? So are those who are have negative antibody that they are more resistant to treatment than those with positive antibody?
Yeah, this is a good question. Now we know the responsiveness of treatment of acetylcholine receptor is better than those with negative or triple negative. Now, the anti-musk mostly goes with the bulbar symptoms. They may respond to a biological treatment like anti-CD20. However, they may go into crisis faster than the usual. So usually they are more severe, but once they respond, they actually do better. Those with a triple negative, even in the clinical trials, their response is less successful than those with the seropositive acetylcholine receptors.
And it's actually very challenging to treat because the therapies are limited in seronegative patients.
Yeah. So I see Dr. Ahmad Abu Laban raising his hand. So we'll take the last question from you, not to delay your presentation. Go ahead.
Actually, it's a comment about the triple or seronegative. I think the negative result in the trial is due to the inclusion criteria. Patients with the negative antibody needs careful nerve conduction study and repetitive nerve stimulations and jitter, a single fiber. Not everyone with the good can do like a good job in delineating them. In my experience, the seronegative cases, they have usually mild disease. I don't know what's the explanation for this, but most of them, they showed very good control in the disease. With regard to the first questions, how can I differentiate between disease fluctuations and disease progression? It's almost the same. Patients can experience worsening of symptoms due to like upper respiratory tract infections, or even sometimes they can fluctuate and worsen despite being a good control. There is a great heterogeneity in myasthenia gravis patient that still we don't understand up to date.
Yeah, thank you, Dr. Al Bulaban. And a final question for Dr. Al Anoud. In your opinion, what is the current gap in the management of myasthenia gravis? So now we have effective new monoclonal antibody and new therapies like immunotherapies to treat myasthenia gravis. But in your opinion, what remained the current gap in the management of myasthenia gravis?
Yeah, so those therapies are available, but not widely available, not in all centers. It's available in, tertiary advanced centers and even tertiary advanced center, because of the cost efficacy, the mode also of giving those medication. It's kind of, challenging to tailor it to certain patients.
Yeah, I can't agree more. So the cost and the accessibility of these new therapies is the main challenge today, especially like in our Middle Eastern country, where we have some countries affected by socioeconomic factors and areas of war. Thank you, Dr. Al Anoud and Dr. Al Roghani, for a very insightful session. And I will move to our next speaker, and it's always a pleasure to introduce Dr. Ahmed Shatila, who is a consultant neurologist and head of the multiple sclerosis clinic at Mafra Hospital in Abu Dhabi. He completed his neurology residency and clinical neurophysiology fellowship in the USA and has been extensively involving in neurology care and MS care and education and research regionally and across the UAE. Dr. Shatila will discuss today the talk that we are all awaiting for, the novel therapies and the novel therapeutic targets in myasthenia gravis. What are the updates in the management of myasthenia gravis? Dr. Shatila, thank you for being thank you for being tonight with us. The floor is yours.
Thank you very much, Maya, for the kind introduction. It's always a pleasure seeing you. Thank you, IVPN NeuroPsychiatry, for the invitation to speak today. I'd like to thank Gen Farm for sponsoring this event, all the speakers who are sharing great and valuable information. But finally, I always like to thank the audience. None of these events could ever happen without your support. So without further ado, let's share my screen. Place current. Yes, I'm assuming that's it. Okay, now let's. Okay. There we go. Now let's just minimize that.
Yeah.
It's there. Too many tabs. Okay, so there we go.
Yeah, we
So
can.
you see everything, you hear me? So
Yes, perfectly, Dr. Shatila.
beautiful. Thank you. So let's go ahead and start. I'm going to talk about novel therapeutic targets and myasthenia gravis. We're going to do an update, 8:50, so I'll keep track of time. So what are we going to talk about today? We're going to talk about efgartigimod, the mechanism of action. We're also going to talk about the clinical data involving efgartigimod, the study overviews, the design, the demographics, how efficacious it is, and how safe and tolerable this medicine is. And then we're going to summarize everything and hopefully one or two slides. So let's first talk about efgartigimod. Efgartigimod targets the FcRn. Now, what is the FcRn? The FcRn, it's the recycling center for antibodies. Now, antibodies, pathogenic, non-pathogenic, they get recycled through by the FcRn. And the way it works is, if you look at this color code right here, you've got the yellow thing that's efgartigimod. The blue one is the IgG antibodies. The red ones are the bad pathogenic antibodies. And I don't know what color that is. Turquoise, maybe? It's the FcRn. So what you're going to see on the same picture, 4 little circles, right? Everything outside the cell is outside. First step is all the antibodies get endocytosed, right? So you have in the endocytosis vesicle, you've got the FcRn receptor, which is on the wall. In the middle of it, you see all the antibodies, the good antibodies, the bad antibodies, and the FcRn blockers. Once it gets endocytosed, it has to be acidified. Once it's acidified, you'll notice then FcRn or efgartigimod will bind to the FcRn receptor. And now what's novel about it is once efgartigimod binds to the FcRn receptor, it blocks other antibodies from binding. And what happens if you can't bind to the FcRn receptor, you get degraded because it's an acidic environment. So whatever gets degraded doesn't get saved. And whatever binds to the FcRn will get recycled. So in a way, I always like to say that it's a way of chemical pheresis. That's what you're doing. You are chemically pheresing these patients. Efgartigimod is an IgG antibody, and pathogenic antibodies are internalized, as I mentioned. It blocks the FcRn, leaving the IgG antibodies and the autoantibodies unbound, which I already mentioned. The unbound antibodies and the autoantibodies enter the degradation pathway, which is facilitated by an acidic environment. It does not impact IgM, IgA, IgE, or IgD. It only affects all the subtypes of IgG. As a result, you have fewer antibodies. As a result of fewer antibodies, fewer pathogenic antibodies, and hopefully that should give us a positive response for our patients. Now, you're going to notice you've got 3 slides right here, 3 pictures. The one on the left is your normal, what it looks like. You've got your FcRn receptor, which is bounded to albumin. In the middle, that's your IgG. If IgG binds to FcRn, that will be saved. FcRn replaces that, it replaces the IgG with efgartigimod, as you can see right there. Now, efgartigimod took its place, which means that the IgG antibody is no longer bound, so that's going to get degraded. The third slide, or the third picture, it's really the same idea, but the only difference is these are other FcRn blockers. Efgartigimod doesn't bind to albumin, thus it doesn't affect albumin and anything that binds to albumin, such as medications, cholesterols. So in a way, you're getting rid of the antibodies, but you're not affecting cholesterol metabolism. You're not affecting how other medications are bound to albumin, thus increasing the plasma concentration of these medications. So it only affects the autoantibodies, but doesn't really affect anything else. And that's a good thing. It's one less thing to worry about, right? So what are the study overviews that have shown? There are many studies. Now, argenx is the company that makes efgartigimod, and they've been really active. You're going to see there's a lot of trials for adults, a lot of trials for pediatrics. Some are acute, some are chronic, different formulations. Some are phase 3, some are phase 4. So what are we going to talk about? You've got the ADAPT. That's the phase 3's randomized, multi-center, placebo-controlled trial looking at the efficacy and safety of IV efgartigimod, 10 mg per kg versus placebo. The ADAPT Plus, that was the open label extension, where now we were looking at the long-term safety, tolerability, and efficacy of IV efgartigimod. Again, it's still 10 milligrams per kilogram. You've got now the ADAPT SubQ, which is looking the same idea, but now we're looking at subcutaneous efgartigimod, different formulation, and they're looking at 1,000 milligrams SubQ versus 10 mg per kg IV. So now you've got competitor, 2 different formulations, one SubQ versus a medicine and a dose that we know already works. And then you've got the ADAPT SubQ Plus, which is the open label extension, safety, and tolerability. What are the other trials? We've got the ADAPT Next and the ADAPT Early. ADAPT Next is a phase 3 randomized open label parallel group study looking at 2 dosing regimens, 10 mg per kg IV fixed cycle versus 10 mg per kg every 2 weeks. And then you got the ADAPT Early. This is a phase 4 open label perspective, single group, multi-center, and they're looking at the efgartigimod SubQ. What about, are there any other patients that we're looking for? You know, myasthenia is not just an adult disease. It can happen in pediatric population. So you've got the ADAPT Junior, the ADAPT Junior SubQ, and the ADAPT Junior Plus. Same idea. The Junior is the phase 3, phase 2, phase 3 open label looking at efgartigimod for people versus placebo. The SubQ, same idea. Now we're looking at the subcutaneous version of this medicine to see if it helps. And ADAPT Junior is the open label extension. So let's first talk about the ADAPT Plus and the ADAPT, let's talk about the ADAPT and the ADAPT Plus. So how was the study designed? It was really, there was active competitor, efgartigimod 10 mg per kg versus placebo. You had 167 patients with generalized myasthenia gravis, MGFA 2, 3, and 4. So the ocular patients were not included. They did include acetylcholine antibody positive and negative patients, but we're going to notice that the positive, we're going to focus really on the positive. Other trials are going to look more particularly in the negative acetylcholine receptor antibody, and you had to have an MG-ADL of more than 5. As Dr. Raed said, your MG-ADL is an 8. It's an 8-question score. 0 is normal, 3 is severe, 24 is the worst of the worst, 0 you have nothing. So you have to have 5 and above. And there was a 2-week screening. So how was it given? In the ADAPT trial, they got 2 cycles of efgartigimod, 10 mg per kg every week for 4 weeks. You waited 1 month, you did it again, and then we watched them. And then where are we here? 4 weeks, we already said that. You could get up to 3 cycles in 26 weeks. The maximum time between cycles was 4 weeks. And the criteria for initiating a second cycle, you had to have 8 weeks since the initiation of the previous. So that's 4 weeks for the medicine, 4 weeks in between medicine, so that's 8 weeks. You had to have an MG-ADL of more than 5. That would help guide you if you're going to give another dose. And for responders, no longer CMI, you had to have a loss of 2-point improvement compared to baseline. So they had to have worsening of more than 2 points. Usually we say three or more is considered clinically meaningful. 2 points, this was the study they looked at for 2 points. A little bit not as stringent, but still pertinent or reflective on our patients' quality of life. The ADAPT Plus, now this was the open label extension. There was the Part A. Now, the only difference was in the ADAPT trial, everybody that was on efgartigimod continued on efgartigimod. Everybody on placebo was given the option to go to efgartigimod. So now we had 84 placebo, 84 active group. Combine them up, we now have 151 patients. And if you really look at it, that's 80 and 80 is 160, 167. So out of 167 people, 151 decided to go into the trial, and that's pretty good. You know, that actually tells you that people liked the medicine, it was relatively safe, and they wanted to be in the trial. So how did they do it? We had Part A, that's where people got 2 cycles 4 weeks apart. Part B, they received more than 2 cycles, and usually this was based on certain characteristics. As I mentioned before, you had to have more than 4 weeks between cycles, you had a worsening of more than 2 points, you had to have an MG-ADL of more than 5. So what were the demographics? You're going to notice that there was really no significant difference between the patients, whether it was age, gender, race, MGFA. Now, one thing here is you're going to notice that this was not for mild patients. You had patients grade 3, you had grade 4. So these are some pretty sick patients. These are not the 0s and 1s, you know what I mean? The mild patients. You also had acetylcholine receptor positive. To a lesser extent, you did have some MuSK patients, only 3, so it's not a lot. So that's why we say we still focus on acetylcholine positive patients. And you had people that were on other treatments. They were not naive. They had other immunosuppressive medications, steroids, and non-steroid immunosuppressants, as you can see. What about the efficacy? Myasthenia gravis activity of daily living, the MG-ADL, and the quantitative myasthenia gravis QMG response. So how did these people do? You're going to notice right here in the MG-ADL, 67% of the efgartigimod patients responded, only 29% of the placebo. And that's pretty typical. You know, the myasthenia gravis is one of those diseases where the placebo group also does respond, almost like your migraine studies, right? Your migraine placebo patients get better. The only difference is it's not sustained. They're not going to stay good forever because it's not really doing anything. But, you know, in the beginning, you're going to get to feel good. They're going to feel like something's happening. But give it the test of time, you're going to notice that this placebo is placebo. If we look at the secondary endpoints, it's still consistent. 63% in efgartigimod, we're down to 14% in the placebo. And how many people respond within 2 weeks? Almost 85%. And that's really what I noticed. I noticed a lot of patients will respond within the first 7 days. You'll start noticing a difference. Now, if you look at this Christmas tree plot right here, MG-ADL, this is the improvement in your MG-ADL. 2 is the minimal difference, but as you go up, it's getting harder. Like I said, 2 is a relatively it's a less stringent curve. So you will get response, 77 in efgartigimod, but you also get 48% of placebo. But as you make it harder, meaning that you need to have a more documented, significant response, it's getting less. The placebo group is not going to maintain that response. The efgartigimod now starts outperforming the placebo by a lot. You're going to notice grade 3, that's what I consider as a significant, meaningful difference. It's almost twice, 2.5 times different, 73 versus 36. And what about the QMG? The MG-ADL is a patient-reported outcome. The QMG is a physician-reported outcome. So you're going to notice either if you're looking at the way the patients look at it or the physicians, this drug works. What about minimal symptom expression or MSE? Same idea. Now, oh God, this thing, it always blocks. I'm just moving. Okay. The rate of minimal symptom expression was seen across the ADAPT and the ADAPT Plus. So you're going to notice there was a significant difference between the placebo group and the treatment group. Almost 4 times as much people in the treatment group benefited. That is significant. ADAPT Plus, anytime up to 19 cycles, 40% of people had minimal symptom expression, which is like an MGA-ADL of 0 or 1. That's pretty impressive by itself. Next one. Response to efgartigimod was sustained across treatment cycles. You're going to notice whether it was cycle 1 or cycle 2. It was sustained. 67% of people responded in the first cycle. 70% responded in the second. It was a little bit better. And this actually gives faith that even if you don't respond in first, you may get some people responding in the second cycle, but it doesn't drop. The placebo group stays relatively unchanged. What about quality of life? You're going to notice here that the quality of life is better, whether you look at the EQ5D, EQ5D, or the MG quality of life. The treatment group does better. And you can notice this is statistically significant. There's a significant change from baseline in the treatment group versus the placebo. And that's what we want to our patient. We don't just want them to be stronger. We don't want them to feel like they're doing better, getting back to their quality of life. What about safety and efficacy? Adverse events, whether you're looking at the placebo group, the treatment group, or the extension, there's no change of anything. The adverse events drop a little bit. It drops 50% in the open label extension from 7.2 to 3.5. You look at serious adverse events, it's pretty similar. 0.3 in the placebo, 0.1 in the treatment, 0.2 in the long-term extension. The most frequent adverse events were headache, nasopharyngitis, and nausea. And it's not common, maybe 1 or 2 people. I've given around more than 15 patients efgartigimod. I think headache is probably the most frequent, and it's only like 2 or 3 patients that have actually complained of headaches. So they get it, but it's not really that significant, and a little bit of Panadol does wonders. Observational data from clinical trials suggest that let me move my screen again. This thing keeps that. Yeah. Observational data from clinical trials suggest that the IgG response to vaccines is not blocked. So that's good. You do get the protective effect of your vaccines. It doesn't affect with your immunization status, does not interfere with the IgG vaccine response to people who received PCV or PPSV23. Patients receiving efgartigimod effectively responded to PPSV23, that's the pneumococcal serovalent 23 vaccine. Does not block IgG response to COVID-19 vaccination. That's nice. We're still talking about COVID 5 years after COVID, which I guess it's never left us. So in summary, efgartigimod is a human IgG1 antibody Fc fragment that has demonstrated a substantial reduction in IgG levels via blocking of FcRn, mediating IgG recycling, as I showed you. The ADAPT trial of efgartigimod in generalized myasthenia gravis showed early, deep, and repeatable benefits with significant improvement in daily living activity. Minimal symptom of expression and real-world studies were consistent with data from the ADAPT clinical development program and shows efgartigimod may help patients with GMG achieve minimal symptom expression. And overall was generally well tolerated, whether we were looking at the ADAPT Plus, ADAPT SubQ, ADAPT SubQ Plus. It all showed the same thing, that this is a relatively safe drug works and not a lot of side effects or things to worry about. So, that's it. So thank you very much. I am done, and I
Thank you,
think I
Dr.
was on. I think I was on time.
You're perfect on time. Thank you, Dr. Shatila, for a very eloquent presentation. And I would like to ask you to stay with us for the Q&A session after Dr. Abu
No
Laban
worries.
presentation. So now I move to our final speaker, and always ختامها مسك, with Dr. Ahmad Abu Laban. Dr. Abu Laban is an assistant professor and consultant neurologist at King Saud bin Abdulaziz University for Health Sciences and National Guard Hospital in Riyadh. He completed his MS and neuroimmunology fellowship training at Yale University and has an extensive track record in research, teaching, clinical leadership, and very recently in AI use in the different neurological disease. Thank you, Dr. Abu Laban, for accepting our invitation. And Dr. Abu Laban will share with you real-world clinical cases of myasthenia gravis from his clinic, and he will share his expertise with us on how to really manage this complex disease in real-world practice. Thank you again, Dr. Abu Laban, and the floor is yours.
Thank you, Dr. Amaya, for the nice introduction. Do you see my slides?
Yes, perfectly.
Bismillah ar-Rahman ar-Rahim. Thank you, IVPN and Gen Farm for the invitation to present about myasthenia gravis, which is really a very important topic. And as I strongly believe, myasthenia gravis patients are really undertreated, and maybe probably underdiagnosed as well. This is my disclosure. I will go briefly about, I'll show two cases, and then I'm gonna talk more about efgartigimod dosing and what's the effect on the use and non-steroidal immunosuppressive medications effect. So this first Mahal is a 66-year-old male with known long-standing history of generalized myasthenia gravis, more than 20 years, and he had uncontrolled symptoms uh, despite different line of treatment, and he had only mild diabetes and hypertension. This is his background. He had thymomectomy before. He had positive acetylcholine receptor antibodies. He had several treatment before in the past, and including plasma exchange and IVIG and Imuran. He's diabetic on metformin and is not like poorly controlled, and also mild hypertension and dyslipidemia, and this is his list of medication. This is the timeline of his disease course. He was diagnosed since 2002, and he was started in Imuran, had the thymectomy in 2010. He started to follow in my clinic in 2020. He experienced worsening of symptoms. We increased the dose of Imuran. We tried short course of steroid, and we did pyridostigmine adjustment. I added rituximab, and he received at least 1 year of treatment of rituximab, and unfortunately, we were not able to control his disease. Rituximab works very well with myasthenia gravis, but not with all patients. When we started his efgartigimod, he had significant change. If you can see, as we all now know what is the MGDL. His MGDL was 5, changed to 2, and MG quality of life changed from 17 to 3. That is very significant. And he stated that I had more than 90% improvement. And as per him, شفت العافية. And also, he used to say I was ashamed with mitosis, and now I go to family meetings with no embarrassment. It was really embarrassing to him, and he used to have more fatigability. He had significant improvement after the treatment with efgartigimod. Another patient, Hissa, short case, also a 35-year-old female, more than 10 years since the diagnosis. She had thymectomy in 2001. and had multiple treatment with no success. She had multiple exacerbation in the past, and even to the degree she was not responding to treatment, to the degree that we thought that she had a muscle disease. She had multiple workup that yielded negative workup. So she only had myasthenia gravis. She had rituximab in the past where it was discontinued as she was labeled as allergic to rituximab. When I saw her again, I said we need to reintroduce rituximab as it's only, it's like a very good treatment. We need to use rituximab, and I gave her 2 years course of rituximab. And literally, what shocked me, and again, as I said, rituximab, I don't want you to be biased by these two cases, but rituximab works well in myasthenia gravis, but not in with every case. This patient, I will use her quote exactly, and I told her, "How did your life change after rituximab?" She said, "As if you give me water. It was nothing." And I was like really astonished by this thing. So, and she had uncontrolled symptoms, the burden, despite different line of therapy with no significant comorbidity. After the Efgartigimod, she had significant improvement. She was able to return back to work, and her ADL dropped from 6 to 2. She used to have she noticed clear improvement from the first dose, and she thought that this is a magic medication. The one of the beautiful thing about Efgartigimod, it's rapid onset of action, where it really can change patients' quality of life. Patient is very young, and she was able to return back to work. Otherwise, she was having difficulty to get agreement from her work to just stay at home and work from remotely, which has really impacted her quality of work and quality of life, of course. So we'll move to the dosage administration of Efgartigimod. What we learned from the trial and from real world evidence is that we administer medications in cycle. Each cycle is 4 doses once weekly, and then you can spare after 40 weeks. You can start with the next cycle, but you can displace it according to the patient response over time, and this is really good. And you can adjust the dose according to the patient's schedule and the patient response to treatment. One way of approaching this is you give 4 doses, and the dose is 10 milligram per kg. Maximum is 1.2 gram. And you can give first 3 cycle, fixed cycle. So 4 weeks on, 4 weeks off, 4 weeks on, 4 weeks off, 4 weeks on, 4 weeks off. And then you space out as per the patient's control of the disease, and you monitor the response accordingly. The target that we want to reach is something called minimal manifestations state, or clinically meaningful improvement, or you can notice it by patient's activity of daily living or by the MGADL. If the patient is doing good, you can start increasing the interval by 1 week, or even holding the medications for a period. Or if not, you can just go with fixed dosing interval, and then you space out as you go. And this is a beautiful thing about the medication. You can really adjust the medications. In the ADAPT trial, the duration of patient spacing between every cycle, it can reach up to more than 9 weeks in 1/3 of patients, and in 1/3 you can in 1/3 it was less than 6 weeks, and in between 6 to 9. Again, the dosing interval between cycles is flexible, and you can adjust in the dose along with the discussion with the patient's plan of expectations. Now, what is the effect on Efgartigimod? Why we want to use Efgartigimod? I mean, definitely the goal always is we want to use less steroid and immunosuppressive medications. The there was high rate of steroid use at the initial phase of the trial before the patients enrolled in the trial, as was shown by Dr. Shatila. Patients were receiving steroid, high percentage of patients on steroid. And this is really in real practice. The steroid is very good, but carries high burden of side effect and complication, diabetes, hypertension, and some patients are diabetic to start with and hypertensive, and steroid will bring complication and will cause immunosuppression and osteoporosis, ulcers, you name it. Patients had uncontrolled disease and very low quality of life at baseline. The possibility of to reduce steroid was not recorded in the trial, but they required the patient to be on a stable dose for other medications in order to see the real response of efgartigimod on their highly active disease, as was mentioned by Dr. Shatila. The acetylcholinesterase dose need to be stable for 2 weeks. Steroid need to be stable for 3 months. Non-steroidal immunosuppressive medication need to be stable for 6 months. And what about real world evidence in these two studies? The first one showed significant reduction in daily dose of prednisone, and the average dose reduced from 29 to 9.5, and even one patient was off steroid. You know, if off steroid is really a good success in treating MG patients because of the cumulative dose side effect and risk that comes with these medications. And in this study in US, the dose reduced, and you can see the drop in every patients. 5 patients were on less than 10 milligram doses after 6 months. This is being feasible after starting efgartigimod treatment with really flexible dose adjustment. This is another study in Italy. Patients, 79 of patients received steroid, and then after the start of the efgartigimod, this reduced significantly, and even patients were had 33% reduction in the dose of the prednisone, and that is really good. What about the non-steroidal immunosuppressive medications? You can check here the from as compared to baseline to 12 months, the number of patients with 3 of dosage, where it's a 0 milligram, 35% were off mycophenolate, which is the Cellcept, and 32 were off Imuran at 12 months. You see the percentage of medications increased gradually. And patients will be happy whenever they can decrease the medication. They will come and ask you, can we reduce the dose of steroid? Can we reduce the immunosuppressive medications? Well, the priority first always goes to the steroid, followed by non-steroidal immunosuppressive medications like Imuran and Cellcept. What is the target? What is the goal? What we want to achieve in myasthenia is minimal symptoms. And there are two definitions, either minimal manifestation status, where the patient has no symptom, but just mild weakness on exam, or if you want to take it objectively by a score of 0 or 1 on MGEDL. Whatever definition you use, that is the goal. Many patients with myasthenia gravis think about their disease that they walk around with the MGADL of 4 or 5 or even 7, and they think that this is how they should live their life, and they are on high dosage of mestinon. I don't consider this as a controlled disease. If the patient is using high dosing interval of pyridostigmine requiring like 1 or 2 tablets every 4 hours, these patients will soon exacerbate or deteriorate with any stress in life, like sleep deprivations or upper respiratory tract infections. So that is very important to notice. Always remember, myasthenia gravis can kill patients if untreated well. They can go into respiratory crisis and they can go into respiratory failure. Now, in the German guideline, they labeled the medications. If Efgartigimod is one of the medications that can be used for acetylcholine receptor antibody positive, and you can consider it in seronegative patients. We participated in large multi-center clinical trial for use of Efgartigimod in seronegative myasthenia gravis patient. The result of the study is still not published, but I think the study will be positive. We'll wait for the official announcement and the official result. This is from the German guidelines, and the second line and third line treatment will be also shown again in another table. They defined refractory myasthenia gravis by one of the three definition. If the patient is having two exacerbation within the 1 year, or if they have MGFA of 2B, or if the patient is having persistent symptoms in daily life, or one severe exacerbations, myasthenic crisis in the last year despite adequate treatment. Or the third thing is the patient persistent symptom relevant to daily life, even if mild to moderate, that is persistent for 2 years. Again, I strongly believe that MG patients are undertreated. Many patients take it for granted. They think that this is the disease, and this is how they just accept it. This is how they should deal with in their life. And I'm sure we should change this, and we need to educate people about and also physicians about the new therapy, where now really the expectation is high. Now, in Germany, in German guidelines, they categorize disease control into 4 levels. Number 1, when the patient is having no disease activity, no symptoms, and freedom of any disease activity, that is free. Level 2, when patients presenting with minimal symptoms or incomplete remission. Level 3, when the patient is having frequent fluctuations and developing new symptoms and also plus minus crisis. 4, when the patient is not responding to treatment, and these usually patients are very sick. Sometimes patients, they don't respond to treatment, and for unknown reason. And I like the question was asked earlier about the fluctuations. The myasthenia gravis patients, they do fluctuate for reason that we don't know. We know sometimes, but also they fluctuate for unknown reason, as we don't understand a lot of things about the disease. This table summarizes the German guidelines, where they categorize patients into either ocular or acetylcholine receptor positive or MuSK, with a first line and a first choice, second choice, and different line of treatment. And even they suggested that you can use autologous stem cell transplant for refractory cases or highly active patients. I think in the coming years we'll see more and more medications, not only targeting FcRn or complement, but a more novel mechanism of actions in targeting B and T cell therapy, or cell-based therapy like CAR T cells. The future for myasthenia gravis treatment is really promising. Summarizing what I've said, the dose of efgartigimod is 4 weeks on, 4 weeks off, and you can do spacing as much as you can. But with early difficult to control disease, you can give 3 consecutive cycles, and then you space out according to the patient response. We learned that with efgartigimod, you'll be able to reduce the steroid dose and also non-steroidal immunosuppressive medications, hopefully to reach the goal of minimal manifestation status and minimal symptoms expression, whatever you like. Thank you.
Thank you, Dr. Abu Laban, for this really very insightful presentation from an expert in the field and the management of myasthenia gravis, for sharing with us these real world patient and real world experiences, so we can understand better on how do you use those new therapy, and how do we manage our patient with uncontrolled myasthenia gravis. So I would like to remind our attendees to write their question for both Dr. Shatila and Dr. Abu Laban in the chat box, so they can answer you. I will start by a question for Dr. Abu Laban. So usually, as I understood, when you start your patient on two therapies like efgartigimod, you keep your patient on low dose steroid, pyridostigmine, and the traditional immunosuppression, and then you can start tapering down after like the first month. What is the approach? How do you introduce and how do you taper the other therapies?
So in Myasthenia gravis, the beautiful thing is we can use a combination from our experience. So it's not like a mess. It's just one medications. You use combinations. We know from our experiences, like anti-CD20 and Imuran is safe, and maybe it's Cellcept, but you need to monitor the patient and risk of complications. The goal, always number one is to remove the needs for steroid. That's number one. And then other immunosuppressive medications. Some patients you will be able to reduce both steroid and Imuran. And then you just keep them on efgartigimod or other medication therapy. Always the way we should think about uh, treatment of myasthenia gravis is upstream or downstream. You're thinking about something that really affect the immune system, not only the downstream, where the downstream thinking only about Plex or IVIG or FcRn or complement. As upstream, other immunosuppressive medications to really target the disease, the B cell producing antibodies.
And in your practice, so those patients who were treated with efgartigimod in the clinic, were they able like to stop steroid, or you keep them like on very low dose, like 5 milligram prednisone, or were you able, when like after months of use of efgartigimod, to completely stop corticosteroid?
So patients were able. I was able in all patients in all my efgartigimod patients. They were able to. I was able to stop steroid very quickly. Some of them I cannot use steroid, so they were not on steroid to start with because of diabetes and hypertension, for example. But most of the time, you can stop the steroid. I would say good number of patients, as I presented in the studies, good number of patients will be able to reduce the steroid dose gradually.
What about your practice, Dr. Shatila?
Yes, Maya, sorry about that. Could you repeat the question, please?
About discontinuing steroids. So the patient for whom you started efgartigimod, like after months of being like stable and they have improvement in their symptoms, were you able to discontinue completely to the steroid, or you kept them like on low dose, like prednisone 5 milligram, or a very low dose of steroids? How do you like taper steroid, and when in efgartigimod initiators?
It's a great question. I personally I have a love-hate relationship with steroids. I think they're amazing drugs, but they're just so bad. You
Yeah.
know what I mean? It's like the benefits outweigh the risks at some point, and you give it long enough, you start seeing how bad they are. Um, some people are steroid dependent, and you can never really stop the steroids, but you try to get them down. 5, 10 milligrams, and you'll notice that that's the best you can get. But I do try to decrease. Now, I don't usually decrease right away. I do want at least them to be stable for at least 6 months. And then I'll gradually start decreasing by what, I could try decreasing by 2.5 milligrams a month. I know there's different regimens, but I like going with a gradual, go low, go slow approach because, you know, this is a lifelong disease and they've been on steroids sometimes for years and decades. So, if the goal is to get them off of it, but there's no rush per se, at least on my side. I don't know,
Yeah.
Dr. Abuleben, if you're different, if you have a different philosophy.
Yeah.
Yeah, so I agree with you. In the old days before the new medication, I used to say to all MG patients, we have to live with the steroid. I mean, but nowadays, no. I have two speed of tapering the steroid, two speed. If they're having higher doses, like if a patient's on 40 or 50, I taper rather very quickly when I reach to 20, like. Every 2 weeks or 1 week I go down the dose. I don't like to keep the patients on higher dosage. And then when I reach 20, I taper rather very, very, very slowly because even the 10 milligram or 5 milligram is really doing big things in myasthenia gravis. So I keep them unless they are disease is very well controlled and they really want to get rid of it or they develop side effect. I taper down very quickly, but I taper rather very slowly from 20 down. I like even every 2 months by 5 milligram.
Yeah, and another question for both of you, like from your practice, what is your target of decrease MGADL to say that this patient is a good responder? So I know there is no like normal or abnormal MGADL score. It's a matter like of monitoring the improvement of MGADL and the like patient satisfaction with his MGADL score. So when do you consider that this drug is a successful medication and the disease like is well controlled? Do you have like a percentage decrease, like if the MGL decrease improved by 30%, 40% from baseline?
Um, you want to go first? So?
Yeah, it doesn't
Yeah, so
matter.
for me, in my opinion, um, uh, I go with minimal manifestation. If the patient is really able to resume really their life normally as much as possible. In like I always like when because I see a lot of MS patient and I always also see a lot of myasthenia gravis patient. In MS, it's very complex. They can have in myasthenia just one symptoms. It's like within the first 1 minute, you would know how they're doing. It's just how you're doing. It is you will know the answer, and it's just almost monosymptomatic disease. It's just a fatigable weakness. If they're able to perform normal in their life, they carry their activity of daily living, they take care of themselves, they were able to like have no fluctuations. How frequent is methylene dose is also an indicator for me. If the patient forgets taking methylone, it's a good sign for me. I always give them the freedom to play with the methylone dose. It is a good indicator that they and I ask patients always to see if you can stop methylone. That's give me a good indication that I'm controlling the disease very well.
Dr.
Yes.
Shetty.
I agree with Dr. Abu Levan. It is somewhat difficult to say what's considered a good response because it's very patient specific. I'll give you the example, the alternative. I have this patient, he has a low MGADL at baseline, but he has one eye. One day, the only thing that happened is that the ptosis, he just had prolonged ptosis in his eye. Well, that becomes a problem when you only have one eye. So even though it's only an increase of like 1 point from 1 to 2 or 2 to 3, that's detrimental. It affects his quality of life significantly. So it's not so much, sometimes you can look at the numbers and see if you're 5 and you go up to 15, that's obvious. But it is very patient specific. But overall, you go back to the patient, you're like, are you satisfied? Do you feel good? Are you able to live your life comfortably and the way you want it? And if they're happy, I'm happy. Ideally, 0 is perfect, but sometimes we can't achieve 0,
Yeah,
so we have to go
yeah.
with the middle ground.
Yeah, and this takes me to another question, like related to the dosage. Dr. Abu Laban in his presentation mentioned that there is no standardized dosing schedule or regimen for FGARTG mode. So it depends. We give usually weekly cycle for 4 weeks and then usually a second cycle, but then we decide either we stop, we monitor, or we start by like increasing the dosing interval by 1 week. What is the dosing strategy that you follow, Dr. Shatila? And then I will take the answer from Dr. Abu Laban.
Uh,
Because this is
and-
sometimes might be
yeah,
confusing, by the way. So probably it's easier like to have a standardized dosing.
yes. Actually, in the very beginning, I'll be honest, I thought it was like something amazing. I'd tell my patients, we'll give you 4 cycles, and then, you go home, and then you come back when your symptoms will get worse, right? Well, the
Yeah.
problem is they don't ever come back,
Yeah,
right?
they never come back. Yeah.
Yeah, they don't come back. So now I've kind of changed a little bit. Now I'm like, you know what? I'm starting to adopt the 4-4-3 model. I give them 4 weeks off, 4 weeks on, 4 weeks off, 4 weeks on. And then I tell them, now you can go home, disappear, come back maybe in about 4 or 5 months. I mean, and I think that works better because when we make it patient specific, it's great. It does empower them, it does give them the power, but then you lose them, and then it becomes kind of hard to follow up. That's something I was facing, but you know, I've been working more with the fixed dosing, at least a 4-4-3, and it appears like, I get long-term efficacy and I can at least get them covered until for a longer period of time. I don't know, Dr. Abu Leban, have you noticed similar problems or issues?
I agree with you. Most of the time, I start with Gartigo mode because it's still not yet available in patients with very severe symptoms. So that most of the time, I use like at least 3 fixed cycles at the beginning, and then I space out as possible. Um, but the knowing the mechanism of action and the patient response is give you more freedom and flexibility with the use of this medication as compared to like different other medications. So I think and most of the time, when I start this medication, my practice is for patients with severe symptoms. That's why I use the fixed 3 cycles, and then I decide based on their response.
Okay. So another question related to when do we use FGARTG mode in your patients? So traditionally we used to use traditional immunosuppressive drug, the oral like mycophenolate, Imuron, and if like we have failure, we can some of our patients were shifted like to rituximab, like the case presented by Dr. Abu Laban, off-label rituximab because rituximab is not approved for myasthenia gravis, but because we didn't have like any other option. So now we have there are multiple drugs that are FDA approved targeted drug for myasthenia gravis, like FGARTG mode specific drugs. So what is your strategy if your patient failed traditional therapy? Do you switch them immediately to FGARTG mode, or do you still try rituximab? Or for some patients, you might start FGARTG mode as first line without even trying like the non-specific immunosuppressive drug.
I can answer this one
Yeah.
first. Honestly, I like the new non-steroidal immunosuppressants. I like the monoclonal antibodies and the next newer generations. Why? First of all, we finally, for once and for all, we have real evidence, clinical trials, placebo-controlled trials that show safety and efficacy. A lot of the other treatments were more anecdotal. Now they're safer, but they also take a lot more time to work. If you go with Imuron, it's like 8 months. Well, okay, that's great. Well, what are you going to do in the next 8 months? Are we going to just give them a lot of steroids and pray? Or do we give them something that works relatively fast and stabilizes them? So it goes back down to availability. If I can give them these medicines, why wouldn't I give it to them?
Yeah.
It's safe, it's effective, it's proven.
And
If I
it's fast.
can give it, then you go with what's available, unfortunately.
Yeah. Dr. Abu Laban, your strategy.
I would say also like because of the medication is currently still not available, I restrict its use to the difficult patients or patients not responding to rituximab. But from the scientific point of view, and if the medication is available, I don't see any restriction with the use of efgartigimod for all patients, even with mild disease. Medication is safe and rapid actions and flexible dosing. And even now, there is a very good and promising service by the company where they give the patients the infusions at home, which is really
Yeah.
very convenient, especially for patients like living outside Riyadh or outside the city that I'm practicing. That is really very convenient. So I think we're gonna use it more and more in the near future if it's becoming available.
And my final question, but it's a question divided into like two sub question. So as you know, like the most common side effect of efgartigimod in the trial was infection, mainly like respiratory and urinary tract infection. So what are the baseline like tests that you do for your patient before starting? So do you do PPD? Do you do varicella? Do you do the whole virology like screening before starting this immunosuppressive drug? So this is one. And two, do you withhold the injection, the infusion in case for example, the patient develop a urinary tract infection or respiratory infection, so he has any active infection and he's due like for his fourth week's dose of efgartigimod, do you withhold it until resolution of the infection like we do with other immunosuppressive drug? And how do you monitor infection in those in efgartigimod treated patients?
Oh, well,
Dr. Shah, you can
yeah, well,
start.
I can go ahead. Well, I did mention that efgartigimod does not affect immunization status.
Yeah.
So ideally, you could immunize during, before, and after efgartigimod. It does have an increased risk of UTIs. But in reality, it's not something we see a lot. If they get a UTI, I've never had anyone admitted for the urosepsis. It's usually mildly, it's treated outpatient. And normally so do I get any baseline screening? You will get baseline screening for every injection, CBC, UA, just basic electrolytes, just to make sure there's no infection. CRP would be good. But if you think about even if they do have an infection, well, the medicine's in their body. So even if you don't give them the dose, well, they're still living from the last dose, unless they're naive, and this is
Yeah.
the first time you're giving it, right? It's like your Ocrevus patient who comes in 6 months later and they have a mild infection or a mild flu. Would you delay the dose? Well, the medicine's lasting 8 months later. It's probably not going to do much. Unless they're so sick that, they're going to go to a hospital and get admitted, I just go business as usual, but I will refer them to infectious disease or internal medicine to treat the infection.
Yeah. Dr. Abu Laban?
I don't see in my practice any serious infection or increased risk of infection. But I require just I monitor the CBC and the immunoglobulin levels. So far, I'm lucky. I have no issues with the medications, and I think it is safe.
Yeah, I agree. So, Doctor, a final question regarding the differences between, like, now it seems that it's the era of myasthenia gravis, and we have a lot like of a new therapy that got suddenly approved. So we have other anti-FcN receptor antagonists that were approved, and other complement inhibitors also that were approved that are also targeted therapy for myasthenia gravis. So what are the key difference in your opinion between efgartigimod and other like competitor targeted therapy?
That's the $1 million question, or the million
To
dirham
end the
question,
webinar with, yeah.
right? Unfortunately, we have no head-to-head trials, right?
Yeah, no, we have
We don't. We know that all these medicines work, but does one work better? We don't know. than the other. But so then we start looking at different, proximity. If you live, let's say, 400 kilometers away, maybe coming every 8 weeks or every 2 weeks may not be an ideal choice, right? Giving patients the flexibility of coming when they need would be better. The sub Qs are coming out. They may be out in some countries. They're just starting to come out in UAE. I don't have experience with it, so I don't really know where to place that in this ever-growing field. But it is getting harder. And I think, at some point each one of us is gonna have our favorites, and we're gonna have certain patients that we like to give drug A for and certain patients we like drug B. But that's gonna be only our own biases, I think, at the end of the day.
Yeah. Dr. Abu Laban?
So I agree with Dr. Shatila that we don't know at the time being, and we need more real-world data and clinical studies. I don't think they will be directly head-to-head, at least in the near future. But in my practice, one algorithm also I use is whenever I want to like rapid action, I will go with the FCRN. And whenever I want like if to see like patients with severe disease, maybe starting to be very weak, maybe I prefer complement. But that's my thought about the mechanism of action. Maybe it give preference. And also just let's remember that some patients respond better to other medications and better than the other. So we need to try and we don't understand this. I'll give you an example. So, which one is superior, IVIG or plasma exchange? Well,
Yeah.
the best way to answer this question is patient's prior experience. If the patients came to you with exacerbation, what did we give you before? We give you IVIG, and you responded very well. Okay, let's repeat it again.
Yeah.
Or he gave you IVIG, did not respond very well. Okay, this time
The
let's try
patient
Glex.
acts as its
Yeah,
own
yeah,
control.
but
So you are
we don't know
comparing.
why some patients
Yeah,
respond better to other kind of medications.
yeah, yeah. So I
I
agree. So really, one of the main advantage of efgartigimod is if fastest onset of action. Whenever we want like fast onset, so I think it has here an advantage and a favoritism over the other. I know I told you that that was my last question, but I still have one question from the audience that I would like to take. It's about efgartigimod and thymectomy. So do we have to space it? When do we start efgartigimod after thymectomy, or it doesn't matter? How do you combine efgartigimod with thymectomy?
I've had a couple patients. Oh, sorry, Dr. Abu speak.
yes, okay, go ahead, go ahead.
Oh, I was going to say, I've given it right after thymectomy. I mean, no problems. I know sometimes after thymectomy, you may need to get IVIG because they could worsen, but I've given it right after. It's not, I really know. I mean, do I have, I think I've even given it to people before thymectomy, they have myasthenia, I give them the efgartigimod, then I refer them to cardiothoracic. So they don't always get the thymectomy right away, right? But we still got to treat them with something until that happens. So I haven't had any issues with A and B versus, giving this or that. I would say one thing though. I know Dr. Abu was talking, and you were talking about the whole that we think we all have our favorites about what medicine works. And I used to be one of those things. I know that we're a little biased that we think if a drug is expensive, it must be good, right? So I used to think honestly that, the complements must be better, hence open quotation, because it's expensive, right? But, I'm becoming pleasantly more and more surprised with efgartigimod. I've had excellent success stories with the complements, but I've also had excellent success stories with the FCRNs. So I don't, I'm beginning to change my own biases on that philosophy as well as I'm seeing more and more.
Dr. Abu Laban?
I want to always remind everyone that thymectomy should be considered as an elective procedure.
Yeah.
So if Gartigomod is there is no they're not contradicting each other. So you have to think that the right timing you're sending the patients to thymectomy. please do not send the patients to myomectomy where their symptoms are very poorly controlled, or because they will suffer. They will have prolonged extubation. They will stay longer in the ICU. So you have to make sure that they are very well controlled, and whether you achieve control by plasma exchange, by IVIG, or by efgartigimod, whatever you want is different. So there is no contradiction.
Thank you, Dr. Abu Laban and Dr. Shatila, for an excellent discussion and really very, very insightful presentation. We really learned a lot from your expertise tonight. And I would like to end this webinar by thanking our 600 attendees who stayed with us until the end of this webinar. And really, as Dr. Shatila mentioned in the beginning, without you, all those educational activity would have not been successful. Also, a big thank you for our sponsor, GenFarm, for supporting us with such educational activity that will definitely help us as a clinician to elevate the care of myasthenia gravis in our region. I would like also to tell our attendees that you will receive your certificate of attendance by email within 1 week of today. This webinar is a CME accredited webinar, and I received a lot of questions on the chat box. Yes, it is a CME accredited webinar by 2CME, by the Dubai Health Authority, and you can just do the equivalency in your country, and you will receive this CME accredited certificate by email within 1 week. Please follow us on social media platform, on our LinkedIn, Instagram, to know more about our upcoming activities, educational webinar. And if you would like to revisit this webinar, which was recorded, you can just visit our IVPN library, within 1 month. It will be posted there, so you can revisit the lectures. Thank you again so much for our speakers, sponsor, attendees, and until I see you again, stay safe and have a good night.
Thank you, Maya, Dr. Abu Laba, and everyone.
Thank you,
Good night.
everybody.
It was a
Thank
pleasure as always.
Always a pleasure, Dr. Shatila. Thank
مع
you.
السلامة. Bye bye.
Bye, 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 bye.